Well, welcome everybody to Samaritan's Purse International Health Forum. We are delighted once again to have you accompany us today. If you've participated with us before, you're familiar with the format. To the right of your screen is a chat box, and we do encourage you to pose questions during the presentation if you feel so inclined to do so. And at the end of the presentation, we also have about 10 minutes dedicated to Q&A. Before we get started today, I'd like to open this up in a word of prayer, and I'm going to call on my colleague Beth Thompson to pray for us.
Father God, we're just so thankful for the opportunity that we have to come and learn and just grow. Father, I just pray that you would be with Dr. Anna as she speaks, and Lord, that you would help us to each grow in our knowledge and understanding and how to care for people in the end stages of their life. Lord, we thank you for the privilege that that is, and Lord, we just pray that you bless our discussion and our time together today. Amen.
Well, amen, and I am delighted today to have Dr. Anna Work from Canada to present palliative care in low-resource countries. Dr. Work attended medical school at the University of Calgary, and she also completed a residency in rural family medicine through the University of Alberta. Anna worked as a rural family physician in Canada, and then thereafter completed a fellowship in palliative care medicine at the University of Alberta. She also has a diploma from the London School of Hygiene and Tropical Medicine. Dr. Work has participated in short-term international medical work with various organizations, including Samaritan's Purse, where she participated in the post-earthquake response after the earthquake in 2010, as well as our cholera response thereafter. Dr. Work has also been involved in running the Ebola holding and treatment unit in Sierra Leone in 2014 during the Ebola crisis. So she comes to us with a great spectrum of experience. Dr. Work is currently a palliative care physician in Edmonton's Zone Palliative Care Program in Canada. And so without further ado, Anna, I'm going to turn the presentation over to you to discuss palliative care.
Great, thank you, Lance, and thank you so much for the opportunity to participate in this webinar. And I just want to thank all the audience listening just for taking some time out to participate in this discussion, and I hope that we can have an interactive conversation today. I know it's tough with being online, and I'm not used to that, so just bear with me. But why don't we get started, because there's a lot of material to cover. So the first slide I just wanted to show you is that with the disclosure, sorry, I just wanted to go back, is that I don't really have anything to disclose except for the fact that a lot of you watching right now may have a lot more experience in doing overseas work, and I would value hearing from you as well throughout the webinar, as well as at the end when we do have more time for discussion. And so what I want to cover today is three different areas, and I just want to start off with a bit of the background of what palliative care is, where it came from, and what it is not, and then talk a little bit about what palliative care looks like in low resource settings, and then incorporate that into how do we integrate palliative care when we're doing disaster response. And so there's each of those talks, each of those objectives can be talks on their own, but we'll see if we can just glaze over some of those, the main topics. So a little bit about the background and history of palliative care. Palliative care, I guess, initially started way back when people who were sick and dying, who couldn't afford to go to hospitals and receive care in those institutions, were somewhat marginalized and needed to find care elsewhere. And this is where the church comes into play, and the community in helping to reduce suffering and provide care. And the modern hospice movement, as we know it, was started off by Dr. Cicely Saunders, who found the need for caring for people who were suffering while at times when they were at end of life and also dying. And she first became a nurse and then worked also as a social worker and then became a physician. And then later, I guess she's now noted as Dame Cicely Saunders. But she started the St. Christopher's Hospice in the 1960s and came up with the concept of total pain, and understood that pain was not just a physical entity, but it also encompassed social aspects as well as emotional, psychological, and importantly, spiritual aspects of pain and existential suffering. So she really advocated for holistic care and a team approach to this. So we talk about whole person care, WHOLE care, as well. Now, where does the term palliative care come from? So Dr. Balfour Mount is a Canadian neurologist and surgeon, and he actually visited Cicely Saunders in St. Christopher's and wanted to create hospice care and palliative care in Canada. So he was instrumental in starting the first hospital-based program in Montreal in Canada in the 1970s. And the term palliative care comes about is because the term hospice had negative connotations, particularly with the French. And Montreal is in a French-speaking province in Canada, and it sort of relates back to the poor and the idea of perhaps receiving second-rate care. And so he developed the term palliative care, which encompasses hospice type of care. So the important thing that is really great to look back on is that palliative care is really based on Christian foundations and values. And Cicely Saunders herself was a follower of Christ. And along with that, her colleagues were as well. And similarly, the 4 physicians who were instrumental in the palliative care movement in Canada were also believers as well. So that's, it's that calling to care for people in need and who are suffering. And there is a French word that it's accompagner, and it's the sense of that is to come alongside someone in their journey and to be radically present at that moment and to provide good care with love and compassion. So I think that's really something important for us to understand, that this does have Christian roots. Now, the idea of terminology, we'll talk a little bit about this later, is terms and definitions change all the time as we move along. And so what is hospice? What is palliative care? Now, hospice, there are a couple definitions with that. And it can mean a physical building, a place where people go to spend the last days, weeks, or months of their lives. And that's generally what we talk about when we mean hospice. Now, correct me if I'm wrong, but in the States, it's more of policy or care for funding in the last 6 months of life. Palliative care then encompasses that, but it's a philosophy of care. It's also a model and approach to care, and now is becoming a recognized specialty in medicine, where you can go into training for further fellowship training in that area. So with the next slide, I wanted to just show you some of the statements that I've heard, or people have some misperceptions. People still don't understand what palliative care is. It's still, a fairly new kind of concept to some people, and so I just want you to have a look at some of these statements. And I don't know if some of them resonate with you, if some may be clearly obvious to you whether they're true or false, and some you might not be so sure about. And I think every day I encounter someone who has who's not quite sure what palliative care means. And so just to think about any other statements or any other questions you may have about palliative care, and hopefully some of those can be answered throughout this talk, and if not, we can definitely ask them throughout and also at the end of the presentation. So I want to talk a little bit about what palliative care is, and the next slide shows the WHO definition of what palliative care is, and I just underlined some of the key points here. And it's meant to improve the quality of life, not only of patients, but also of families. And usually it's when people have a life-threatening or incurable disease. And the aim is to prevent and relieve suffering. So, we talk about medicine and what are the goals of medicine, and I think one of the goals of medicine really is to relieve suffering. And then early identification, and I love this word, impeccable assessment. You know, they could have just chosen to put in assessment, but it's not just a so-so assessment or an okay assessment, but it's an impeccable assessment, and then that helps us to provide excellent quality care. And again, here is again the idea of total pain and symptoms which involve more than just physical suffering, but psychosocial and spiritual as well. And the WHO also has the a separate definition for children, and they mention that 98% of children require palliative care, and about half of those are in African countries. And so, you know, we don't want to forget about the children, because I mean they make up a lot of the population especially in low resource and middle income countries. And now I want to talk about what palliative care is not. And it is not euthanasia. It's not the active, intentional ending of someone's life. It's not only about the last phases of life, the last days or hours when people are imminently dying. And there's always something more than that we can do. And I think it's difficult, because if I can get the foot in the door, that's great. But oftentimes people will say, no, I don't want palliative care. Please leave, or you know, don't even give me that opportunity to talk to them about what it is, because people have misperceptions of what it is, and they either think you're here to see me because that must mean I'm dying right this minute, or you're here to end my life or shorten my life. And so it has some wonderful connotations, but unfortunately it can have some negative connotations for some people. So the next slide, I wanted to talk a little bit about terms and definitions, and I think partly we perpetuate the confusion. And you know, I don't know if you've heard that term, you know, say what you mean what you say. And so sometimes I feel like most of the time that I'm talking to people, I spend a lot of time just trying to get us all on the same page. And when I say one term, I just want to be sure that everyone is aware of what we're talking about and that we are on the same page. So I'll spend a little bit of time on this just because I think it is important, particularly in Canada right now. As last year, some of you may be aware that the Supreme Court of Canada had struck down this long law of against assisted suicide. And so we've gone how many thousands of years with it being illegal for euthanasia, physician-assisted suicide, and all of a sudden now it will become decriminalized. And that's actually, the government had a year to come up with legislation. So as of February 6th this year, which is in a few weeks, it will be decriminalized. So what does that mean? And the government now is pushing to extend that period of time to come up with legislation, because honestly, it's not as simple as people think. There are so many implications, and it is really, I guess, a scary time that we're entering into right now. And so, again, palliative care is not physician-hastened death, which is the term that the Canadian Society of Palliative Care Physicians is leaning towards, to give it that that sense of urgency that it is hastened, because the assist sort of quotes it a little bit for some people. Physician-hastened death then includes physician-assisted suicide as well as euthanasia. So the first one is that a physician can give you a prescription, say, to self-administer to shorten your life. And euthanasia then is that the physician would actively be the one to administer the drug. Now, a lot of people, even Christians, will say, oh, of course I agree with euthanasia, but I think there's a difference, and some people don't quite understand that the refusal, withholding, and withdrawal of treatment that may be futile is not the same as euthanasia. That, you know, we can allow nature to take its course and allow a natural death, and that is not hastening death intentionally. And so I think it is important to really clarify some of these terms. Now, the term medical aid in dying I have there is, it sounds great, but I think it's a euphemism, and Quebec actually was the first province to actually bring euthanasia into effect. So as of December, it is legal, and they call it medical aid in dying, which really they mean euthanasia, not physician-assisted suicide, which Wikipedia says, so don't trust everything that the internet states. But in fact, they're really talking about euthanasia. Now, they termed it medical aid in dying because health is a provincial jurisdiction. Euthanasia is illegal federally. And so by changing the term, they could make laws about it under the provincial jurisdiction. So Dr. Balfour Mount, again, the father of palliative care in Canada, says, what do you mean medical aid in dying? That's what we've been doing throughout our, throughout what we do in medicine, is we help those while they're dying. And so there is just a lot of confusion around some of these terms. And again, I think it's important to call a spade a spade. So we need to be clear with what we're talking about. So, and the other thing that they talk about is including that with palliative sedation, which again is not euthanasia. It's not physician-assisted suicide, but it is something that we can use for refractory symptoms. So sorry for that preamble, but I think it's important that we talk about some of these definitions. The next slide, I talk about more why the misunderstanding. So, some people don't want to know. Some people feel that they don't need to know about palliative care, end-of-life care, or they don't realize that they don't know. And some of them, frankly, just don't care, or they say that someone else will do it. But I think it's really important that we all have a good understanding of what this is, and that it is an important part of medical care and in general care as well. So with the next slide, then, I just want to bring us back to the idea of community and coming alongside one another to help people out. We've sort of, in society, have focused more on medicalizing the idea of death and dying, which is more really a social event than anything. And we need, I think, more education about death and dying. And it's something that is still taboo in many cultures, and many patients still don't want to talk about death and dying, but it is a reality. Everybody must go through it. So Jean Vanier is the son of a former Governor General of Canada. His sister actually was one of the palliative care physicians who worked with Cicely Saunders at the very beginning, and Jean Vanier has created a faith-based community for adults who have disabilities, who live with their assistants, and it is community living. And I had a great opportunity to live in a community years ago, and also and continue to be involved in this community. So, in doing rural medicine, it's just that idea of there's just something about being in an environment where you can rely on other people, and that's what God has called us to do, is to live in community and not separately. So sorry for spending a lot of time on that, but I just wanted to kind of give you a sense of what palliative care is, where it's come from, and then now we'll talk a little bit about what palliative care can look like in high-resource countries when you have the resources and the funding to be able to provide palliative care. So there are various programs and models, and not everything is going to be perfect for each setting, and it really has to be tailored for that particular area. So things include acute care services, where you have consultation services in acute care settings, or you may have an outpatient multidisciplinary clinic where people can come and go, for example, in a cancer care treatment center, where they come in and get their chemotherapy, but also can be seen by palliative care physicians. You can also have it home-based or community-based, where home care support can come in and help people while they're spending the last days of their life at home for as long as possible. And then if they need to, move into a hospice setting, an actual building where they can receive more care that they can otherwise. We also have special palliative care units, which have interdisciplinary teams that focus on the very, very difficult to manage cases. And so those may or may not be appropriate for certain settings, but certainly in high-resource countries there are many available. Again, it's difficult because we, the high-resource countries, we think, well, everyone must have palliative care access then. But actually, in Canada, there is a stat that says that only 16 to 30% of Canadians have adequate access to palliative care. So there's still a lot of room to move, and a lot of work that can be done in places where we have the funds. So think about the challenges then when we start to talk about places that don't have a lot of resources. The thing that I want to emphasize is that you can still receive concurrent curative treatment. So palliative care doesn't start when there are no further curative treatments offered or available. It starts at the time of diagnosis and is offered throughout someone's illness. And again, we go back to sort of the assessments. We have tools, we have resources, we have investigations and labs that can help us with assessing people and targeting what is causing their symptoms, and prognostic tools that give us an idea of how much time someone may have or where to best focus our care. And again, this comes back to the idea of advanced care planning and what are the goals of care that people have. What do they want to see for the rest of their time, and how they plan out their treatment and course. And the other thing is some of the resources and interventions. People just think, palliative, I talk a lot about cancer care because I think that's what we're focused on a lot in higher income countries. We are moving more into more non-malignant cases, but as you'll see later, that's probably more of an issue in more recognized, I guess, in lower resource centers. But cancer, we talk about chemotherapy, we talk about radiation therapy, which can be given right at the get-go, and a lot of people think it's curative, for curative intent only. But in fact, you can be quite aggressive in giving these sorts of treatments for symptom management, and they are sometimes for palliative intent as well. So I'll send someone to hospice, but they can still receive palliative radiation therapy for their bone metastases or their brain metastases if we think it'll help with their symptoms for pain and that sort of thing. And you can have surgical intervention for pinning of long bones to prevent pathologic fractures, or radiation or surgical decompression for spinal cord compression that could extend someone's life in the sense that you could extend their quality of life as well. So the next thing is we'll move into talking about palliative care in low income and middle income countries. So a bit of background then. The next slide shows just some of the numbers of non-communicable diseases, which is huge. So 56 million deaths in the world in 2012, and 38 million of those, which comes out to be 68%, were due to non-communicable diseases. So that includes things like cardiovascular disease and pulmonary disease. Cancer, if you look here, constitutes about 22% of the NCDs, and it's not put as much in the forefront as it may be in higher resource settings. And then I also want to just mention HIV and AIDS, which is much more common issue that we deal with in low-income and middle-income countries than we may perhaps do in higher resource settings. So the next slide, if you look at the first statement, palliative care is integrated in only 8.5% of health systems. And then if you're looking at the second line, you're thinking, wait a minute, isn't that saying the exact same thing? And in fact it is, right? It's just a different way of putting it. And I think that brings me also to the point of how do we present information to people? It basically says the same thing, and either way you look at it, they are staggering numbers. And so we know that in these certain countries there is a high burden of disease, there's not enough palliative care, and particularly not great access to medications for pain. And we'll talk a little bit about opioids in a minute. So the next slide just shows a bit of pictorial. I'm sorry that it's a bit fuzzy there, but just an idea of where some of the palliative care integration of these programs are. You can see North America, Europe, Australia are ones with the most development in palliative care, and that little one in sort of East Africa there, that dark green is Uganda, which we'll talk a little bit about. So on the next slide, again, there is awareness of these issues, and particularly in disaster response situations like the complex humanitarian emergencies, HIV. So not just cancer, which I think we tend to just think about when we think about palliative care and people who are dying. So these are some of the countries that have some programs in place. Uganda has Hospice Africa Uganda, which was set up by Dr. Anne Merriman. And it's interesting, again, we need to think about what is appropriate in that setting. And in that case, there's really collaboration and cooperation with the government and Ministry of Health. And really, they have changed policy in that setting, the nurses are actually trained to prescribe opioids, which isn't the case in a lot of places. And it's worked for Uganda so far. And you know, she really, Dr. Merriman really talks about how opioid access should be, you know, for everyone, and it's relatively cheap. She talks about how morphine costs, you know, the same as a loaf of bread, and so Uganda actually ranks 35 on the 2015 Quality of Death Index, with UK, Australia, and New Zealand ranking first, second, and third. So doing not too badly. The next slide then shows talks about the different methods, or how do we provide palliative care in these settings. And home-based or community-based palliative care is probably the most common, just because of the resources available, and that it seems to work in more of these settings. I don't know if hospital-based palliative care programs, they may or may not work, and I think that really depends on the country and what's available. But again, it needs to be integrated into what's already existing, and not a separate program. It's not meant to be either or. You need to have both. And I think someone likened palliative care to something like infectious diseases, where everyone should really be able to provide basic palliative care. It doesn't matter who you are, and it should start from the caregiver all the way up to the specialist. But it's for example, it's like someone having a UTI or a pneumonia. Most physicians and people in healthcare professionals should be able to recognize that and be able to treat that. And it's only when we encounter more difficult cases of infectious diseases that we will consult the service for assistance. But we should be able to provide basic care. Now, there are various documents out there that kind of guide people into what should you think about if you wanted to start a program, and this is one of them. I'm not endorsing anyone, but I just came across this one from the APCA standards, which you can find on one of the websites that I'll give you in the resource section at the end of the talk. And the next slide focuses on, I just wanted to talk a little bit about the prognosis we were talking about earlier, and this gives us an idea of the different trajectories. And so the first one, I mean, sudden death can happen where there's no lead time or anything. You know, you just go along high functioning and all of a sudden you die. Terminal illness, that's the one where we talk a lot more about cancer care. We have a more of a better idea of what the trajectory is. People do fairly well, and then as soon as they start to decline, they tend to decline fairly rapidly. Now, the organ failure, so we're talking things like end-stage renal disease, end-stage liver disease, heart failure, COPD. They have these dips, so they're gradually on a decline, but then they have these dips where they come down, and then people wonder, is this it? But then they surprise us and they come back up again. So it's very, very difficult to prognosticate for non-malignant issues. And I think this, I would think, assumes that they are receiving, quote unquote, the usual or normal care that we would expect. But what happens then if you don't have those resources? Then you throw, things like the social determinants of health into place, and that can really, change the curves and that sort of thing. So the WHO has developed a public health strategy for palliative care, which is the next slide, and it focuses on 4 areas to look at, including national health plans, as well as making essential medicines, particularly opioids, available. And then also the education, again, we talked about from caregiver to the experts, and then how do you implement standards and guidelines. And the next slide is this nice, colorful poster, which is there to advocate for palliative care, and I'll draw your attention to the right upper hand corner, where it's just a pictorial that shows you that palliative care can be given at the time of diagnosis, and as the disease progresses to the right, the amount of palliative care that you may or may not need increases until the time of death. And then something we don't talk a lot about is bereavement or grief support, which is all aftercare, which is a tremendous area as well that needs to be looked at. But again, would go back to the prognosis. People can live with, say, prostate or breast cancer for a long, long time, but then and not need a lot of palliative support until the end, when they are having more symptoms. But just to say that it can be offered concurrently and throughout a diagnosis. So the next thing is we want to just took a look at some articles, and this is actually very important to actually think about, is that just because people are suffering and we want to jump in there, give them palliative care and support as best we can, but we can't forget that it's not an either or. We also, I think, we need to endeavor to provide good medical health care. And so along with advocating for palliative care, we need to also be advocating for good medical care as well. And not forget that disease-modifying treatments such as antiretroviral therapies can prolong life, but it can also improve quality of life. So I think we can't just jump straight to palliative care. We need to have both. And particularly, we need to focus on prevention strategies, early detection, early diagnosis, screening, and treatment in addition to palliative care. So we think about, why are people dying of cervical cancer more so in other countries than in higher resource countries? Well, we need to think about, screening, pap smears, and if you think about vaccination programs and that sort of thing, those need to also be in place. And the next slide shows, again, just that it needs to be locally appropriate and given alongside treatments. But the key thing here is also, they talk about proven effectiveness, and that's, I think, brings us to research and how it's very important that we try to get evidence-based stuff out there, and it's really difficult. Again, palliative care is fairly new, but it has this, I guess the sense people feel about palliative care is that it's kind of soft, right? It's touchy-feely. People will say, well, can you prove that? Where's the evidence for that? And so I think now the area of palliative care is really pushing also for research and for evidence-based articles, which you'll see now. There's a lot of publications out, and it's really to strive for excellence as well in academia, and so it's becoming more and more recognized in that sense also. So the next slide shows some initiatives that are more recent. There's this resolution about trying to strengthen palliative care and integrate it into current programs. And then this Montreal Declaration. Every 2 years there's an International Congress of Palliative Care that occurs in Montreal. This next one is coming up in October of this year if anyone's interested, but it is, there was that call to try to get it onto the Sustainable Development Goals, which replace the Millennial Development Goals. So the next slide, think about these symptoms that you have. These are common symptoms and it can be daunting and overwhelming, but how would you treat these symptoms with the available resources that you have? And how would you approach trying to figure out what the cause of these symptoms are? So, we can talk about medicines and that sort of thing, but with the next slide, it's about if you could pick someone to be on your dream team to help you with palliative care, who would these people be? And this is really the people that should be on an interprofessional team that would help with, again, targeting the alleviating suffering from total pain and a holistic point of view. And in Edmonton here, we do have a tertiary palliative care unit that has actually every single one of these except for maybe the art therapist. We don't have a dedicated art therapist, but some of the other specialists do some work with art therapy. So, and it's wonderful to be able to help people with some of their symptoms with all of these with this teamwork approach. The next slide then talks about the essential med list, particularly for pain and palliative care, which is great. So if you could pick your top medicines and have them in a bag, what would they be? And this is what WHO came up with. And we'll focus on the opioid analgesics because pain is one of the biggest issues that we need to deal with. And morphine is the key one that we'll focus on. And as you see, some of the alternatives they list there are hydromorphone and oxycodone, and there's many other opioids which we won't talk about today. But if you go to the next slide, it's effective for moderate and severe pain. We may need adjuvants for the neuropathic part of things, but it's cheap, safe, effective. But the issue is government control. There's a lot of difficulty with resistance and challenges of fear of drug trafficking, of addiction, and that's still real. I think we're getting better, but it's still, the regulations are so tight to avoid those issues, and I don't disagree that there are problems with that. But then in doing so, you're not allowing the availability or accessibility for pain medicines for people who really do need it. So I've had some colleagues here say, maybe the best answer is just not to have a triplicate pad, so I can just say that I can't write you a prescription. But is that really being responsible? Yes, you're maybe trying to curb the addiction and dependence part of things, but there are people who truly do need opioids for symptom management. So the next thing that I wanted to talk about is that if your pain isn't, if you talk about the euthanasia, physician-assisted suicide thing, if you ask people, why is it that you want to pursue this? And a lot of the times it's not because of poor pain control. So we're fairly good at getting good pain control if we have the resources available. I'm not saying it's 100%, but the majority of people do have good pain control. Well, what happens if you don't have good pain control? Will that then, as some people may suggest, lead people to maybe consider other routes or other options such as a physician-assisted death? I don't know, it's a question to think about. But here is just a pictorial, and you can see where most of the countries that the higher resource settings use most of the opioids. The next slide gives you a table graph, and it shows that about 80% of low and middle income countries, or 80% of the world's population, which is in low and middle income countries, uses about 5%, right? So 83 and 6. So 6% of opioids used by the majority of the population. That's pretty sad. So I guess the next slide then I think we'll quickly run through is, this is a window. Lance mentioned that I did work in Sierra Leone with the Ebola response there. And this is, I guess you would call it a window, but it's, again, just talking about the perspective. This is us looking out and our perspective from inside. And what about the perspective of Ebola and care from the outside? So now we're kind of moving into talking a little bit about palliative care in disaster responses. And so these different views, again, perspectives, think about these things. Is palliative care in humanitarian crises a luxury? It's super busy. Is this just one more thing that we have to add on to do? Or, as most people are trending towards, is palliative care an international human right? And by that, there's a lot of papers out that talk about this follows along the international right to health care, and how denying people from pain relief it is inhumane, and not acceptable. And so with that, though, we also want to talk about adding everything else in, right? So people having good nutrition, water, sanitation, hygiene, that sort of thing. So this encompasses a lot of different things. So we can talk a lot about different disaster response things, the scenarios such as the earthquakes, war zones, cholera outbreak, and I mean, I don't have a lot of experience with disaster response, and I'm sure that a lot of you out there do. But I just want to talk a little bit about the Ebola response and from a palliative care perspective. And I'm not going to talk a lot about the epidemiology, but just more about the palliative care part. So if you go to the next slide and just give you some context. So this is West Africa, Sierra Leone, in West Africa, and you can see the bordering countries Guinea and Liberia, which were also affected by the Ebola outbreak. And I was based in a small community outside of Freetown. So the next slide, in palliative care, we like to talk about stories. And in general, humans, we all have our own story to tell. And it really is important to take the time to listen to someone's story, and that can help us to give better care. So quickly then, I just want to give you a bit of background on Sierra Leone's story. So we talk about the languages. English Creole there is not just, not to be confused with Creole, the Haitian language. This is more of a fusion, I guess, between English and one of their native languages, taking a look at the religion and the backgrounds there. So it is quite tolerant, if you can use that word. I'm not a fan of that word, but more so than in places like Canada or the US, which is very interesting, actually. They've gone through slavery, colonialism. So if you think about it, the three countries that were hit by this were all at one point in time colonies. So Sierra Leone, British colony, Guinea, French colony, and Liberia ties to the United States. So, there's a lot of backstory that sometimes we forget and is important to realize. So they had independence, and then they went through civil war, and then you've heard about the child soldiers, and you've probably watched the movie Blood Diamond. And then on top of that, let's just throw Ebola into the mix. And the next slide just shows you where they kind of started from. These are their numbers. In brackets are Canada. Sorry, that's this also comes from data in August of 2015. I think they came out with some newer ones, but that's sort of where it was, and it was just in comparison to Canada. So that's where the second number comes from. So really, if you look at it, not starting at a very great place. Next slide. On top of all that, what happens then when you lose your dedicated, limited physicians, healthcare professionals to Ebola? So there were not a lot of personnel, healthcare personnel, because they were dying. And so what you do is we try to pull people from different areas. So the next slide then, again, at the time there's no proven treatment. The big thing was early supportive care. So in this sense, we kind of knew what we were dealing with, in the sense that palliative care was pretty much a guarantee that if we weren't able to do things, I mean, that's what we do in disaster response, right? We try to save as many lives as possible. But what happens when we can't save everyone's life? I think it's important that we recognize that, and then give the care that is deserved. But in Ebola, it was, we kind of expected that there would be a high mortality rate. So we tried to give a lot of fluids. ORS, the oral rehydration salts, was key. And there was, for some people, not a lot we could do. But there was hope, and if you provided early care, early supportive care, and it would make a difference. So the next slide, then, we want to think about concurrent treatment of other infections. There's other stuff happening. People are still having strokes. They're still having cardiovascular problems. These things don't stop, as you're well aware, during a crisis. There was some question of whether or not we should be prophylactically treating everyone, but certainly if they did have other infections, we wanted that treated as well, and then some other management options. And again, the next slide is just about prognosis. This is what we knew about Ebola, and some characteristics that would lead to a better or worse prognosis. But really, at that time, it's hard when you're kind of dealing with a lot of unknowns. And, we want to make sure at that time, though, that if people are experiencing other issues, that we need to manage those as well. The problem was most of the hospitals that were already existing there were overwhelmed, and they were dealing more with Ebola patients. So there were no or limited places where we could send people who did not have Ebola, that you could manage other ongoing care needs. And there was a risk of, a measles, and I think there might have been a measles outbreak because other programs had declined. So, the vaccination programs and such. So the next slide we talk, I'm just going to run quickly because I'm just cognizant of time here, is that this was what our multidisciplinary team was, pretty well everybody. And a lot of these people were actually survivors. And so they had a lot of input in caring for these patients as well, not just in their role as listed here. But the psychosocial spiritual team was vital, and everyone recognized that this needed to be in place even before we started. So the next slide, again, the challenges. If you think about people who have Clostridium difficile or people who need to be isolated in our center, you've got actual barriers. You've got the gloves. You can't, the basic things of good communication skills, eye contact, human touch. This was all kind of thrown out by the wayside, right? You've got these goggles that would fog up. You couldn't really touch people without being in protective equipment. There were barriers, fences that would physically separate families and friends. They'd have to yell over the fence, that sort of thing. So, and then we talk a little bit about the determinants of health that can affect the challenges of providing palliative care. The next slide, some of the limitations. We had some paracetamol for fevers, avoid NSAIDs because of the bleeding, but no morphine, no codeine, but we had tramadol. I don't know where that came from. And so really there were not a lot of medications. There wasn't a lot of stock in our setting initially until later on. Now, this is a tool that you can find on www.palliative.org. It's called the Edmonton Symptom Assessment Scale, which helps to determine symptoms, but you can use visual analog scale or anything that would help to assess people's symptoms. And it is a validated resource, so you can go on that and to the site to get that as well. And the next slide is psychosocial issues. These are some issues that we need to be aware of, and also the stigmatization of, even if you weren't tested positive, you were in the center. And so even if you're negative, you were in and involved in that area. So people will look at these people who have had contact with an Ebola center differently. And it's really tough, and we also hear about some of the side effects and some of the issues that are ongoing with the survivors of Ebola as well. And the next slide, I guess, I know there's a lot of, it sounds really quite, is there hope? And I think there is. I know a lot of this stuff is kind of heavy for a morning to talk about or an afternoon to talk about, but we always have to remember that we're there to care for people and to do so with compassion. And the next slide quickly is just about the barriers, and we can look at that. There is still lack of political will. It's not a popular thing, but again, it's not to stop the funding for HIV, TB, malaria, but it's to bring on palliative care alongside. And I'm just about done. So the next thing is just about response. I put pray first because it's something that I also know is that I leave as a last resort, but it's something we should be doing right away and first and foremost. Get involved. Get more. There's lots of educational resources, which I'll leave at the end here, and advocate for universal access to comprehensive, high-quality, fully integrated palliative and end-of-life care, not only in high-resource settings, but also in lower and middle-income places, and to support one another in community. We're called to bear one another's burdens. And then what Paul says, you know what? How do we respond? Really, this is what is the most excellent way, but love. And then the next is just some resources for you to look at, and there are lots of information there about international palliative care, and so it's not endorsing any one organization, but there are lots of stuff there you can look at. And then finally, I just want to leave you with a quote from Dame Cicely Saunders: "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but to live until you die." Thank you so much for this opportunity, and I'm sorry I ran a little bit over time, but I want to just open up to questions if there are any.
All right, Anna, I just want to before we delve into questions, I just want to say what an incredibly dynamic presentation. I worked for a year and a half in palliative care and hospice, and I learned a lot through your presentation. I'd just like to open up by saying that having also, now that I work in disaster response and internationally, there's tremendous need for more access to palliative care and end-of-life care, and I think you've done a superb job in addressing that, and so I hope that will occur as we move forward. I know, just having been on some of the front lines, you did an excellent job of presenting with regard to Ebola. There was certainly, there was a very limited ratio of care providers to patients, but there certainly was a tremendous need for palliative care in the Ebola epidemic, and like I said, in a multitude of other situations too, both through infectious disease and non-communicable disease, as you've addressed. But to our listening audience, there's the chat box there. Please pose questions, and we will entertain them as they come. I'd also like to say that Anna's resources will be included in our follow-up email, so that you'll have access to resources with regard to palliative care. All right, I don't see there thus far, Anna. I don't have any. You must have done a thorough job, because so far we don't have any questions. But
that or everyone's sleeping.
No, I don't think so. So we do have a question. Well, I'm sorry. So far we don't. Yeah, but no one's sleeping. So it was a phenomenal presentation.
Great, thanks. I forgot to suggest that the WHO also has a lot of resources, as well, as I'm sure you're aware, and then you can also get resources from the Christian Medical Dental Society, or the which I think in the United States is the Christian Medical Association, and in Britain it's Christian Medical Fellowship. So there's a lot's happening on that front as well too. So.
Okay, great. Anna, we do have a question. It says, how to find potential funding sources for faith-based institutions in low middle-income countries struggling to provide palliative care services. Much demand, little resources available.
Wow, that's a loaded question, and I'm not sure I can answer that. I think it's also comes back to funding for other types of care, as well as disease-modifying care as well. It's really tough to get the resources, and how do you sustain that? I mean, you can have donors, but at some point that may or may not run out, and that's a difficult question, and I don't know, I might want to throw that out to some of the other audience members, or even to Lance yourself with your experience.
Yeah. Let me preface my answers by saying I'm not sure I have a definitive answer, but I think one is just to recognize the need to incorporate palliative care as a comprehensive medical response in disaster response, and when we request for funding, that could be incorporated in the request and the programming, and I think it could be incorporated in funding could be incorporated in that fashion. Yeah, I don't know. Anybody else? Yeah. And while I'm waiting to see if there's any more questions, let me just conclude with reminding everybody that we do have CME available. You were given in your email, you were given directions, instructions to complete your Q&A or your questions for obtaining your CME. I do want to remind everybody that that is time sensitive, that that you need to submit that within a week to definitively receive your 1 hour CME credit. So I encourage you to do that. We'll also receive soon via email, you'll receive a recording of this excellent presentation by Dr. Work. And that also, as we've already mentioned, that will be accompanied by resources. Included in those resources were some made available by Shelley Enerson, who works for African Palliative Care. So we'll have some excellent resources made available to you. Yeah. And then also just want to encourage our listening audience with regard to disaster response here at Samaritan's Purse. We do have applications for what we call DART, our Disaster Assistance Response Team. If you call Samaritan's Purse and request for the HR department, they can make available to you via the internet DART, medical DART application, so that you can potentially participate with us in the future with medical disaster response. So, yeah. Anna, again, a great presentation. Again, you must have done an extremely thorough job. I thought you would be inundated with questions, but I don't see any other questions. So with that, the only other thing I just want to say, a thank you to you. That was superb. Next month, on February the 10th, our next presenter, Dr. Stephen Mary, will be discussing cost effectiveness in resource-limited settings. So please do join us for that presentation. And with that, we will conclude here at Samaritan's Purse International Health Forum. Thank you for joining us.